what she does, okay? But I'm going to kind of steal her thunder a little bit here because you're seeing me first, okay? I'm going to tell you that there's two kinds of surgery you can have. You may already know what they are, okay? Either of them will work, and I want to be very clear with you that whichever one you pick, you have the same expectation of cure. You know what the two kinds of surgery are? Okay, one's a mastectomy, meaning she'll take the whole breast, whole left breast, okay? And the second one is what we call a lumpectomy or a partial mastectomy, meaning she'll only take out the lump of tissue that contains the tumor. Okay, she'll take out the smallest amount she can, getting the tumor out clean and leaving you with the rest of your breast tissue. Okay, so you might be sitting there thinking, well, how can a smaller surgery be better than a larger surgery? Well, here's the answer. It's not that lumpectomy is equivalent to mastectomy. It's that lumpectomy plus radiation is equivalent to mastectomy. Because the breast, we'll draw on the back of this, okay? So let's say here's a breast, and here's the nipple, and there's all these ducts that lead up to the nipple, right? All these ducts. And all these ducts have branch points, and they have lots and lots of branch points. So I'm not drawing it very well because I'm a good musician but a bad artist. But all these network of ducts connect to each other. So a tumor grows somewhere in there. Let's say it starts right here. And sometimes a few cells can escape off down the ducts. And Dr. Lamb is going to come in and take out a piece of tissue like that if you decide to have a lumpectomy, but there may still be a few cells that got away. And that disease is called microscopic disease because you can't see it on any scan. It's too small. The mammogram won't show it, an MRI won't show it, a PET scan won't show it. Too small. And she can't feel it with her fingers when she's in there either because it's too small. But it's there. And what the studies showed us is when women have a lumpectomy and no other treatment, the chance of the cancer coming back in the breast from the microscopic disease is about 25%. Okay? Now that's not 100%, but that's still not a very comfortable number for me to live with. So what is the job of radiation? Radiation kills the microscopic disease. So then your risk of recurrence drops down to like 3%. So that's what the radiation is for. And that's how a lumpectomy can be equally effective to a mastectomy. Mastectomy, you take all the breast tissue away. There's no more ducts left, okay? No more cancer, no more ducts, okay? With a lumpectomy, you're leaving a lot of the breast tissue in the ducts, which may have this microscopic disease, but someone like me comes along and kills the microscopic disease. So the point that I'm trying to make to you is it's really your personal preference, whether you want to have a lumpectomy or a mastectomy. I don't care which one you pick because you can get cured either way. You just have to agree, if you have a lumpectomy, to come back and see me and let me give you some radiation. Okay? So that's the next decision that you guys are going to be asked to make, is what kind of surgery to have. And Dr. Lamb's going to go over all this again. To some people, this really matters a lot, so I'm going to mention it. After you have a lumpectomy, most people are going to go home the same day. It's basically an outpatient surgical procedure, and you go home with no drains, okay? After a mastectomy, more tissue comes off, you're going to go home with a couple of drains that you have to take care of for a few days, and you're going to be in the hospital for a night or two, okay? That matters a lot to some people, okay? Now, on the other hand, some people say, I live in Cedar Key, and I don't want to drive over here for several weeks for radiation, so I'm having a mastectomy no matter what, right? People have different priorities and different preferences about it. So that's going to be up to you to kind of give us some guidance, what you prefer, what you guys prefer, and what's easier for you. And I'm going to answer all your questions about what it's like to have radiation and all that stuff, so you'll be able to think about it, okay? But that is the next decision point for you guys, is what kind of surgery to have, because surgery is number one in the treatment pathway, okay? Okay, I want to throw one more thing out there about breast surgery. Okay, I have lots of women that come in here saying, I'm going to have a mastectomy and not a lumpectomy because I know my cure rate is better with a mastectomy. And then I have to explain to them everything I just explained to you. No, it's not. Absolutely not true. Data says no. Okay, you can't argue with the data. We got 30 years of data on this now. Okay, so it's not the case. So it's a personal decision. It's not a medical decision. It's a personal decision. Okay, no medical reason why you have to pick a mastectomy over a lumpectomy. Okay, number two, a lot of women come in and say, I'm going to have a mastectomy because then I won't have to have the chemo. Okay. Now, I don't even know if chemo is on the table for you. For a lot of women with a good profile and a small tumor, chemo is not needed. And I hope it's not needed for you. Okay? Even if it were needed for you, You still can't avoid it with a mastectomy because do you know what chemo is for? I've explained to you what radiation is for, right? It's to clean up the microscopic disease left behind in the breast, okay? Now, when the cancer cells get out of the duct, they can go to the lymph nodes and into other places in the ducts, and they can also go into the bloodstream. Eventually, cancer cells end up in the bloodstream. And once they're in the bloodstream, they're floating around, right? They're not in your breast anymore. They're floating around all over your body. That is what chemo is for. If we have a high suspicion of microscopic disease in the bloodstream, we recommend chemo to kill it. Now, tell me this. If you need chemo to kill microscopic disease in the bloodstream, does it matter what you do with your breast surgery? Doesn't matter. Because the idea is we're killing disease in the bloodstream, not in your breast. Okay, that's what chemo is for. I'm thinking you're going to not have that to worry about. Okay, the risk of you having microscopic disease in the bloodstream is so low that I don't think we have to worry about that. Okay, but I'm explaining why that's a fallacy. Okay, having a mastectomy is not going to free you from the recommendation for chemo if chemo is right for you. Okay, so all that in mind, we're going to come back to this at the end, but your next job together is to decide what kind of surgery to have. Okay, and after you meet with Dr. Lamb, she'll explain the same thing to you and ask you to think about it and come to a decision. Okay, so you ask me any questions that come to you along the way. Okay, I'm going to start writing down a plan down here. Number 1 is surgery. And number 2, for people who need it, is the chemotherapy. And I'm going to put a huge question mark there for you because I'm thinking you're not going to need it. Okay, but I'm putting it for completeness. Okay. Number 3, if you need it, is radiation. And if you have a mastectomy and everything comes back negative, you don't need it. If you have a lumpectomy, yes, you need it. Okay? And last of all, and this one is definitely going to be offered to you, is anti-estrogen therapy. And that's just a pill that you take. Okay? Now, why do you need that? Go back to here. Remember, your breast cancer cells are strongly positive for the estrogen receptor. And even way after menopause, we all still have some estrogen floating around in our bloodstream. Not very much, but we have some. And it will bind to those estrogen receptors and stimulate the cancer cells. So taking anti-estrogen therapy stops that from happening. And it also reduces your lifetime risk of another breast cancer in either breast, if you have that concern. Okay? So that's the whole sequence of treatments that could potentially be used for you if you need them. Okay? Mm-hmm. And now I hope you're having some understanding of why you have all these different doctors and these different things that could go on. Okay? Mm-hmm. And why we recommend those things. We don't just recommend them to torture you. Okay? We recommend them for a reason because we're trying to cure you. Okay? Okay. So we've already talked about this being your next decision point, deciding between a breast sparing surgery or a lumpectomy and a mastectomy. And the other thing that Dr. Lamb will talk to you about is we want to make sure that the lymph nodes here that we talked about earlier are negative. Now in the old days like 1970 and before, every single breast cancer patient got a mastectomy and all the lymph nodes taken out. Every single one. Didn't matter if they had a tumor this size or this size. They all got a mastectomy and a full lymph node dissection. We don't do that anymore because you don't have to. Okay, it's completely unnecessary. It's unnecessarily destructive and disfiguring. Okay, so now we can do lumpectomies for small tumors, and we don't have to take all these nodes out. There's literally dozens of nodes along this pathway. We only have to take out the first couple along the drainage pathway from your tumor, called the sentinel nodes. So when Dr. Lamb takes you to surgery, she will do a sentinel node procedure. Just 1 or 2 nodes that'll come out. And if those are negative, the rest of them that are farther down the pathway are going to be negative as well. So that will be part of your surgery as well. Okay? It's a lot, isn't it?
That's why he's recording
It's a lot. That's why you're recording it, and that's why you brought more than just 2 ears. Okay? That's always good. Okay? And you're going to hear it again too. Please.
Got a couple questions.
Please.
With her dementia, has there been any studies on the different surgeries?
The biggest risk with dementia is anybody going under anesthesia, including a young, healthy person. It's going to be a little goofy. Anesthesia is a hit on your system. So a shorter, smaller surgery is probably a better idea.
Now, these 2 surgeries, one's longer and one's shorter?
Mastectomy is longer. You go home with drains. The recovery is a little a little heavier.
Okay.
So I recommend minimizing surgical exposure. And I really think that chemo is not going to be indicated no matter what, but even if it is, I would think really hard about giving it, and Dr. Dickerson will tell you the same thing. I would avoid it no matter, try to avoid it any way you can.
Now, everybody tells me this can't be a factor, but it is a factor for us. Cost.
It's a factor for everybody. Do you have Medicare and no secondary? Is that the idea? Okay.
And that, of course, this lady gave me a whole packet of things to study up on
Yes.
getting help.
Yes.
So that we don't have to make a decision on the price of stuff.
Gotcha.
Because I understand
Ask-
radiation is higher than,
I think lumpectomy plus radiation would total up to more than mastectomy. I believe so. I don't swear to that. I don't do surgery, so I'm not that up on the surgical costs. I'm sorry about that. But I'm pretty sure that a mastectomy would cost you less than a lumpectomy plus radiation.
right.
I'm pretty sure.
That's what I understand.
Yes. Yeah, the way we deal with cost here is it's expensive for anybody getting any course of radiation for anything. So, we ask people for a certain amount down, and then we work out a payment plan. That's the way we generally manage it.
So how much do you ask down?
I have to get my financial people to do that with you. I think we usually ask for 10 or 20%, but I'm not positive about that.
Well, I know everything's covered except for 20%, and that's where we're at right now.
20, whatever your part of your obligation is, we ask for that percentage of
Right.
that.
Oh, that percentage of that. So
Not 20% of your entire course of treatment, 20% of whatever
20% of-
you are going to owe out of your pocket. And what we don't know about your breast cancer yet for sure is called the stage. And stage is very important because until we know the true stage of someone's cancer, we can't be clear about exactly what treatment they need, okay? So until we're done with your surgery, we don't have your full staging. But based on your mammogram and ultrasound, and I'm going to examine you in a few minutes, based on those things, I can make an intelligent guess about your stage, okay? So I can be reasonably confident about the things that I'm going to describe that you're going to be offered today, okay? Just keeping in mind that I don't know for sure yet, okay? So instead of talking about pathologic staging, which is the true staging, the gold standard that we base our treatment on, we're going to talk about clinical staging, which is the intelligent guess staging, okay? So my intelligent guess, you can take this piece of paper home with you so you can photograph it all you want, okay? My intelligent guess about your staging is you're going to be a T1 tumor. So T for tumor, it's all about the size of the tumor, okay? If you're anything under 2 centimeters, you're a T1, and the scale goes all the way up to T4. And yours, based on your mammogram and ultrasound, looks like it's between 5 and 10 millimeters. So less than a centimeter.
Oh, okay.
Okay? So I'm going to guess, my intelligent guess is you're a T1B. My second intelligent guess is about nodes, N for nodes. You know what lymph nodes are?
I've heard of them, but I don't
Okay.
really understand.
Do you know how when people get sick, like with strep throat or an upper respiratory infection, you can get the glands in your neck swollen? Those are lymph nodes.
Okay.
Okay? And lymph nodes are all over your body, not just in your neck. They're little tiny kidney bean shaped filters, and they catch anything that doesn't belong. They catch bacteria and germs. They catch coal particles in coal miners. They catch asbestos particles in shipbuilders. And they catch cancer cells that are trying to spread away from primary tumors. Okay? So the lymph nodes that matter for breast cancer are these ones here. If you get a cancer in your right breast, the first place it might spread is the lymph nodes running under the armpit and under the collarbone. Okay? So based on a small tumor size and the fact that nothing was seen abnormal in your lymph nodes on the mammogram and ultrasound, my intelligent guess about your lymph nodes is N0. Okay, meaning no disease in the lymph nodes. Dr. Lamb is going to talk to you about surgery, and she's going to prove that. Okay, and I'll talk to you a little bit more about that in just a minute. Okay, but she's going to get some tissue out and prove that. Okay, now the last part of staging is M for metastasis. Do you know what metastasis means?
Where it spreads.
Yeah, it means a cancer that grows enough where it gets into the bloodstream and spreads to other parts of your body, which is obviously not what we want to happen. Okay,
Right.
and I have no reason to think that that's you, none at all. And in fact, if you're a T1N0, the chances are 99% that you're also an M0. So I don't think that concern is even going to be on the table for you. Okay, so that's my intelligent guess about your staging. Okay, so let's have the rest of our conversation presuming that to be true. Okay, let's presume that to be true, because I'm pretty sure it is. Okay, so how to cure breast cancer, how to cure an early stage breast cancer, because I think that's what you have. Okay, there's one more piece of information that I'm going to write down here, which is called your biologic profile of your breast cancer. And when they did that little biopsy, they sent the tissue off for some special studies, and they looked at three things. One is called ER, that does not stand for emergency room, that stands for estrogen receptor. Okay. One is called PR, that stands for progesterone receptor. When I say estrogen and progesterone, you know what I'm talking about? That's the hormones that make you female. You have a lot of those and a little bit of testosterone. He has a lot of testosterone and a little bit of estrogen. Okay.
Okay.
We all have both, but the proportion makes all the difference in terms of our secondary sexual characteristics. Okay. And the last thing that we're talking about is HER2 new. Now, why would we be talking about estrogen and progesterone with a breast cancer? Because a breast cancer cell comes from a normal breast cell. Okay. Cancers are not like infectious diseases. They don't fly in from outer space and attack us. We don't catch them from other people. They come from our own normal body cells, just by a bad luck process, okay, most of the time, okay? So normal breast cells have estrogen and progesterone receptors because that's the signal that tells a breast to get ready to make milk for a baby. When you get pregnant, your levels of estrogen and progesterone shoot up by about 10,000, a factor of about 10,000 in a few days. And everything in your body starts prepping for a baby, including your breast cells. Okay? So breast cancer cells come from normal breast cells, and therefore sometimes they carry with them the estrogen and progesterone receptors. They still have them. And it's a good thing if they do. And guess what? Yours do. So your ER is 95% positive, and 80% of the cells are positive for the PR. And the last one is this thing called HER2 new. Stupidest name you ever heard of, right? Some biochemist made that up on a bad day, all right? It is also a receptor on the surface of the cells, okay? The estrogen receptor binds to estrogen in your bloodstream. The progesterone receptor, same thing, binds to progesterone in your bloodstream. The HER2 new receptor binds to something called a growth factor. Now, what do growth factors do? They tell the cell to grow and divide. Is that what you want happening to your breast cancer cells? Heck no. You do not want them to grow and divide. Okay, so what you want is to be negative for HER2. Your test on your initial tissue came back equivocal, meaning the numbers were right in the middle and they couldn't tell yes or no for that. So here's what's going to happen for you. We don't know the answer for the HER2 yet. When you get your surgery, the whole tumor is going to get sent for a repeat test, so we get the final answer on that. Okay? So we just don't know this one yet. Sometimes that happens in a small percentage of cases. It's just equivocal. They don't have enough tissue to tell very clearly. Okay, it's below the resolution of the test, basically. So don't lose any sleep over that. It's going to be repeated on your tumor tissue when you get your surgery. Okay, no problem. You can think about a needle biopsy. They get the tiniest little amount of tissue inside that needle, right? And they have to do all these tests on it, and sometimes there's just not enough. So no worries about that. We're going to put a question mark on that one because we just don't know yet.
Now,
And we will
because
find out.
that's a question mark, that doesn't mean she doesn't have cancer.
No, sir. We are absolutely clear and unequivocal about the fact that you have a small invasive breast cancer right now today. Okay? These are characteristics of the cancer that help us decide what best treatment to offer you. Okay? And so far, the strongly positive ER and PR are good things. Okay? The best profile to have is a high ER, high PR, low HER2. And we just don't know about the HER2 yet. Okay? But we'll find out. Okay? All right, now let's talk about how to fix it. Okay? So if you are truly a T1N0 breast cancer, that's an overall stage 1 breast cancer, we are very, very successful with stage 1 breast cancer. Okay? The cure rates are better than 95%. They're better than 98% for people with a favorable biologic profile. So what I'm trying to get across to you is you have every expectation to get cured of this breast cancer and live on to die of something else a long time from now.
Okay. That's
Okay?
good.
So
That'd be good.
that's my plan for
My
you.
children would love that.
Yes.
My husband.
And the way we get there, the reason we do so well with the cure rates these days is we have multiple different weapons to throw at breast cancer. Okay? So that's why you have a whole team of 3 doctors now instead of just 1 doctor. Because the weapons we have are surgery, that's Dr. Lamb, okay? Chemotherapy and anti-estrogen therapy, that's Dr. Dickerson. And by the way, I'm not saying that you're going to need chemo. I'm not saying that. A lot of breast cancer patients don't with the early stages, okay? But that's something that she does if it's needed. That's Dr. Dickerson, and the third weapon is radiation, and that's me. Okay? Now, not all breast cancer patients need all the different things I just said, okay? It depends on your stage and what kind of surgery you decide to have, et cetera, okay? But those are all weapons that we have, and that's the reason we do so well with curing the breast cancer these days. So, let's talk about each of them in turn. The most important next decision for you to make is what kind of surgery to have. And Dr. Lamb's going to talk to you about. So radiation, and this is the way chemo works too, by the way. They both differentiate between cancer cells and normal cells by selectively targeting rapidly dividing cells, whose DNA is in the process of dividing. So they selectively damage, greater damage to DNA in rapidly dividing cells. And as that damage accumulates in the cells, they die. And a lot of them don't die right away. They die later because they activate a cellular suicide program called apoptosis in response to the DNA damage. That's technical fine points of how it works, but that is how radiation does its job. It leaves your normal tissue functionally intact, but it kills the rapidly dividing cells within that normal tissue. Because you remember what we're trying to do with radiation to a breast, right? Your primary tumor is gone. It's surgically removed before we do the radiation. What I'm targeting is the microscopic disease that I can't even see because it's microscopic by definition, right? But it's in there, and it is targeted by the radiation very selectively. It's complex, I know. It is. And your radiation's always mysterious, and people are afraid of it because you can't see it. It's invisible, and you hear all about, radiations and radon and da-da-da-da-da. But this is very targeted radiation. We are so careful with it on so many levels to make it go where it's supposed to go.
Now, how many times you have to do them?
21. 21.
Wow.
You're going to come in here 21 times, 15-minute appointments, 5-minute treatment. Takes less than 5 minutes to give the treatment. And you are lying on your back. There are people that run the machines, the radiation machines, called RTTs, radiation therapy technicians. They're the ones who'll come and get you and take you back to the machine and put you on the machine, position you, and run the machine every day. I don't do that. I don't even know how to turn on the machine. My job is to know how much to give you and where to put it and make a plan I'm happy with, which then goes over to the machine to be delivered.
If you had breast cancer, would you do the mastectomy? Would you?
No, not unless I medically needed to. I just don't see the point. And I've seen radiation long enough that I know. I know the ups and the downs and the goods and the bads, and it's mostly good. And I got friends I trust to give it to me, right? So I know exactly who I'd pick out. Dr. Lamb would be my surgeon. My partner Cheryl Hayes would be my radiation oncologist. I would have radiation.
So Dr. Lamb does both surgeries, the surgery.
She does all kinds. Absolutely, absolutely.
Off or
Yes,
in.
whatever you need. Yeah, and if you decide to have a mastectomy and you wish to have reconstruction, I don't know if that's on the table for you, okay? We would also involve a plastic surgeon at that point. That's a lot of kerfuffle, okay? The plastic surgeons sometimes sell it and make it sound really easy because that's what they do, right? But it is not easy. It's more surgeries that you would have to go through. So
The insurance would feel that was a necessary thing.
insurance covers. Insurance will cover. It is a medically indicated procedure. If you wish to have reconstruction, it will be paid for. You'll have your 20% part of it, obviously, okay? But it's more surgeries, more anesthesia for you. So you got to think about that very hard.
What I was going to do to my brain. Yeah, my brain. Yeah.
You were trying to save the body and the brain.
Well, yeah.
I want the body, but, she wants the brain.
I enjoy singing in our choir at church.
Oh, lovely. I was there too.
And
What do you play?
I play piano
Okay, you said an
mostly.
instrument.
Yeah, but I sing too. That's mostly what I do now because
my friends are all praying for me, and they're hoping I'll still be able to be in choir and all that kind of thing. So
nobody's going to do anything to you to damage your voice.
No, I wasn't great about the voice, but
Yes.
yeah, but I'm just saying that maybe my friends.
Oh yeah, you may miss a few practices and in your recovery period, but you're going to be able to sing in the choir. Yeah.
And
no doubt about it.
Okay. Gee. Cost effective. Is it? I guess you shouldn't choose it by that way.
Well, that's what they keep saying, but, we still got to eat.
Yeah.
We'll share that cat food.
No, it's hard on a fixed income. And the older you get, the more likely you are to be living on a fixed income, and that's when you get your cancers too.
Yeah. Well, that's where we are. We're just on the, I had a little hardware store in town.
Mhm.
When we
Yeah.
closed that up, there
Heard.
wasn't anything left, and
Mhm.
so we're on Social Security.
Mhm.
Yeah, and that's tough, it is.
Said how pretty she was, and I didn't. Stop smiling, I wanna get those eyeballs. There we go. Such beautiful eyeballs.
Yes.
You don't know that I was casting a curse on your camera.
That's fine.